Welcome to The Explainer. Today, we are diving into something that can feel like a real maze for any trainee, doing an ERCP on a patient who's had a Roux-en-Y gastric bypass. It's tricky, for sure, but we're going to break it down together. So here's our roadmap. We'll kick things off by really understanding the challenge itself. Then we'll walk through the absolute must-dos in your pre-procedure playbook. After that, we hit the big fork in the road, the one question that changes everything. We'll explore the two main pathways from there before we wrap it all up. Okay, so first things first, what is it about this specific anatomy that makes it such a headache? Let's dig into why a procedure that's usually pretty straightforward suddenly becomes this giant puzzle. Normally, right, an ERCP is a fairly direct shot. You take your side-viewing duodenoscopy, you get down to the ampulla, and boom, you have access to the bile duct to deal with stones, strictures, whatever you need to do. But throw in a Roux-en-Y surgery, and that whole map gets thrown out the window. Suddenly, you're faced with this incredibly long, winding road, a Roux limb that can be 100, even 150 centimeters long, and it ends with a super sharp turn. And your standard duodenoscope? Yeah, it's just not built for that kind of marathon. So when you've got this anatomical maze in front of you, your success really depends on planning. You can't just wing it. That's where your pre-procedure playbook becomes absolutely critical. And these 3 steps, they're totally non-negotiable. First, you have to get your hands on that surgeon's operative note. Think of it as your GPS. It tells you how long the limbs are, how everything is hooked up. Second, look at the timing. And this is a big one. If that surgery was recent, like less than a month ago, you've really got to weigh the risk of messing with those fresh connections. And third, get the imaging. An MRCP gives you a beautiful preview of the biliary tree before you even pick up a scope. Okay, you've done your homework. Now comes the moment that changes everything. Seriously, your entire strategy, everything you're about to do, hinges on the answer to one single question. This is it. This is the fork in the road, the big question. Does your patient have a native papilla? Because the answer to this one question sends you down one of 2 completely different paths, each with its own set of rules and its own toolbox. All right, let's take that first path. Let's say the answer is yes, they do have their native papilla. The goal here is pretty simple, at least in theory. We want to use our trusty duodenoscope, because it's still the best tool for the job. But as we know, that long Roux limb is standing in our way. You can't just drive the scope down the normal route. So if the front door is locked, you've got to build a new one. You have to create a direct shortcut into that excluded part of the stomach to get where you need to go. And this is where things get really cool. We use a technique called EDGE. First, you use endoscopic ultrasound to find that bypass stomach. Then, you deploy this amazing little device, a lumen-opposing metal stent, or LAMS. It creates a temporary tunnel, a fistula, connecting the pouch to the old stomach. You're literally building a bridge for your duodenoscope to drive right through, so you can do your thing. And check this out. This isn't some experimental thing. The numbers are incredible. We're talking a 99% success rate just for placing the stent. And that translates to a 95% clinical success rate for actually fixing the problem. That's huge. So you might be asking, what's the alternative? Well, it's basically surgery, laparoscopy-assisted ERCP. And yeah, surgery has a slightly higher success rate, but look at the trade-offs. EDG is way less invasive, it's a lot faster, we're talking over an hour faster on average, and you get to skip all the risks that come with an actual surgery, like wound infections. Okay, time to back up and take that other path. What if the patient doesn't have a native papilla? Maybe they have what's called a bilaoenteric anastomosis. Now the whole game changes. It's time for the forward-viewing scopes to shine. And once again, the length of that Roux limb is everything. If it's on the shorter side, say under 75 centimeters, you might be able to get there with a regular small bowel enteroscope or even a skinny colonoscopy. But for those longer limbs, you're going to need to bring out the heavy artillery, device-assisted enteroscopy, using things like balloons to help you navigate that long journey. Now, getting there is one thing, but balloon-assisted ERCP has its own quirks. Remember, you're using a scope that looks straight ahead, not to the side. So your target, the anastomosis, is sitting in this really awkward 6 o'clock position. It makes cannulation a real challenge. Plus, the scope is super long, you need special gear. It's doable, for sure, but the success rates reflect that difficulty, sitting somewhere between 60 and 80%. Okay, we've gone down both paths, seen the different tools, the different challenges. Let's pull it all back together. How do you actually make the call for your patient, standing right in front of you? It really comes down to these four pillars. Think of it as your final checklist. First, their specific anatomy. Second, why are you even doing the procedure? Is it a one-and-done stone removal or something that's going to need repeat visits? Third, what's their surgical risk? And finally, and this one is so important, what can your hospital actually do? What's the local expertise? The point is, there's no flow chart with one single right answer. It's got to be a custom plan every single time. So we've laid out the map for you. You have the framework, you know the options. But the real skill, the art of medicine that makes you a great endoscopist, is learning how to balance all of this. The cool new tech like Edge, the reliability of surgery, and the real-world resources you have to make the absolute best choice for every single patient you see.